I'll go ahead and introduce our speaker. I believe we'll be right on time. So I see Dr. Aaron Thompson there. So Aaron, really good to see you, and I'm looking forward to your talk today. And it gives me a real privilege to read a little bit about your bio. So for folks on the call who don't know, Dr. Aaron Thompson, he's a physician, but also sort of staff physician at St. Michael's Hospital, chief medical officer for the Workplace Safety Insurance Board, and also an associate professor at the Telemetry Faculty of Medicine at the University of Toronto. He's going to be talking to us today about hand-arm vibration syndrome, assessment and management, and he is absolutely a leader in this area. As an occupational medical specialist and associate professor of medicine at the University of Toronto, as we said, serves as the chief medical officer of the Workplace Safety and Insurance Board, but also former director of the Occupational Medicine Residency Training Program. And so important, right, that our healthcare providers get training in occupational health and occupational medicine. And I think, again, there's really a gap in many places. And so we're really privileged that we've got Dr. Thompson here to be able to do that work. So with that, again, he's conducting work in clinical and occupational medicine, disability management, return to work, expertise across a number of clinical perspectives, does talks around the world, really a specialist, again, looking at return to work issues and how you deal with accommodations. He's published extensively on the topics of hand-arm vibration, disability experience and prevention, and has co-authored the 2018 International Consensus Criteria for Diagnosing and Staging Hand-Arm Vibration. And I could go on and embarrass him a little bit more, but I think with that, we're best to hear from him. Truly a privilege. Dr. Thompson, over to you.
Thank you so much, Tammy. That was too kind. It's truly an honor to be here this morning. A big thank you to CROSH, to Sandra Dorman for reaching out. It's wonderful to see my colleagues, Tammy Eager, Katie Goggins. And hand-arm vibration syndrome has been a passion of mine since the start of my training in occupational medicine. So I started my training in occupational medicine in 2003. Hard to believe, 22 years ago. And right out of the gate, I was really so lucky to have a colleague in Dr. Ron House, and worked very closely with Dr. House over the years, and then was able to connect and work collaboratively with folks like you, Tammy, and Katie, and lots of trainees, and now, full-fledged researchers and clinicians along the way. So thank you very much for that kind introduction, and this is a topic that's very near and dear to my heart. In terms of disclosures, I think most of them were mentioned. My primary one is that I do work for the WSIB as the Chief Medical Officer, and my clinical practice here at St. Michael's Hospital. I'm associated with some grants, and I do some work in consulting as well. Okay, so we're going to cover some general aspects of hand-arm vibration syndrome, and I'll speak in some detail about certain components. Very conscious of the wide breadth of expertise across the audience in various areas, and so I'm hoping that this is really of interest to everyone. Some parts maybe will be more interesting to the folks with a strong health and safety background, others perhaps looking at things from a research lens. So what we'll do is we'll talk about what HAVS is, basically the pathophysiology. We'll also discuss what causes HAVS. And the main question that most people have is, how much vibration exposure can I be exposed to, or can a person be exposed to before it poses risk? And we'll discuss that a bit. And then the diagnosis. Everyone's always interested, how do we diagnose this condition? It's quite a complicated condition with many different systems involved. So how do we go about diagnosing it? and then finally, prevention and return to work considerations. So Toby, I think we had a poll here just to get an idea of where everyone's coming from. Oh, great. Okay. So if you just take a second to just give a little bit of sort of your main background here. All right, excellent. Okay, so I see that we have close to 2/3 of the audience health and safety professionals. Fantastic. And I'm sure you have some expertise in hand-arm vibration syndrome, so we'll try and round out some of that and answer some questions at the end as well. I see some managers. We have some students with us, which is fantastic. And I'm sure those students also have a research interest as well, and then some other. Okay, great. Well, that gives me a good idea about the audience. So let's move right into things here. So what is hand-arm vibration syndrome? So here's a picture of a younger me in our clinic here at St. Michael's Hospital, and I'm with a patient with hand-arm vibration syndrome here. Thanks to Dr. House for taking that picture. I remember that day. It was many years ago. So what is hand-arm vibration syndrome? It's an occupational disease. It has vascular, neurological, and musculoskeletal systems involvement. So you can see the complexity here. That's, there's many occupational exposures that, will cause a lung disease, for example, or a skin disease, a dermatitis, or maybe a carcinogen. When you get occupational exposures that cause multiple system damage, we use often that term in medicine, a syndrome, to describe the syndromic aspects of it, which all those different components. So here, when we talk about a syndrome of hand-arm vibration syndrome, we're talking about all three of those. And Toby, I know my next polling question was actually asking people what systems were involved, so we can skip that one because I've just given the answer. So this is what we're talking about with HAVS. Now, one of the issues here is that HAVS is not something that's really taught to medical students very often. It's not even taught to residents, including residents that may see patients and that really present predominantly with, say, vascular symptoms, like a rheumatologist or neurologists who see patients with peripheral neuropathy, the numbness and tingling in the fingers all the time. And, it might be mentioned here and there, but oftentimes it's not right there on the differential diagnosis. When a patient presents with Raynaud's phenomenon, that blanching in the fingers, or the peripheral neuropathy, quite often people are not taking an occupational history. They're not gathering that information. They're not putting this on a differential diagnosis. That's a real problem. That's something that CROSH is making huge strides in terms of education and awareness, and hand-arm vibration syndrome is a perfect example. So if we look at how prevalent the condition is, we can see here that there's different ways to approach that question. One was done, it seems like quite a while ago now, in the UK, with sending out a mailed survey and asking people about their work history and whether or not they have symptoms in their hands. And they estimated at that time almost 300,000 cases. In the United States, NIOSH took a bit of a different approach. They knew what the dose-response relationships were, like how much vibration you have to be exposed to develop hand-arm vibration syndrome. So they did have data on basically who and how many people are exposed to hand transmitted vibration, or at least could estimate that. And so from that and the levels of vibration, they estimated how many cases there might be in the United States. And they came up with this number of about 725,000. So we actually don't have any Canada-specific or Ontario-specific data to tell us what the true prevalence of hand-arm vibration syndrome is. But we can look to that work done in the UK and the United States and say, well, we're pretty similar from a workforce standpoint, perhaps. How many cases do we think we have in Canada? And so using that, it's somewhere between, you can see here, 70 and almost 150,000 prevalent cases. That's a lot of people affected, a lot of people affected. We can then look at workers' compensation data, and this is actually a really nice illustration, particularly for the students here today, that you have to be very careful when you look at workers' compensation data and try and extrapolate that to say, this is how common a disease is. Why is that? It's because quite often, either a physician is not recognizing something as being occupational, or an individual person that has the disease or injury doesn't know that it was caused by work. And even when it is recognized, sometimes people are reluctant to file claims. So there's a whole host of reasons. But what it leads to is the fact that when you look at claims data, that's the number of claims that come in, right, to a given workers' compensation board in a given jurisdiction. But it is not necessarily a good reflection of the prevalence of a disease or injury type. So you saw on that last slide, there could be about 150,000 prevalent cases of HAVS in Canada, but you're seeing only every year perhaps 400 to 500 cases being reported to workers' compensation boards. What does that tell me as an occupational physician? That tells me that this is a condition that is underreported. And what then needs to be done? Well, two things. When you have a condition that's that prevalent, we need to really double down on efforts for prevention, right? We have to focus on that. And the other thing we have to do is we really have to double down our efforts on education to make people aware of this condition so that it is being detected early on. And we're going to talk about the prognosis as well, but detecting this early on by clinicians and people that are developing the condition in the early stages so that it can be picked up and that prevention can prevent worsening of it. So education is absolutely essential. Okay, so let's just take a few moments just to do a bit more of a deep dive on what is happening in this condition. So you'll recall the blood vessels can be affected, the nerves can be affected, and the musculoskeletal system can be affected. So the vascular ones are the ones that everyone always is kind of aware of. When they think of hand-arm vibration syndrome, if people have heard of it before, they say, oh yeah, that's vibration white finger, or that's the Raynaud's phenomenon that is caused by vibration. And that's exactly right. This is the most sort of common and well-recognized part of hand-arm vibration syndrome. And we've known about this for a long time. I have a strong interest also in the history of medicine. It's kind of a hobby of mine. Here, actually, hand-arm vibration syndrome is not a new thing. Dr. Alice Hamilton, the mother of occupational medicine, first female faculty member at Harvard University in medicine, she published on this in 1917 and again in the 1930s. So this was recognized even in the late 1800s, basically when pneumatic tools and vibratory tools started to be used. So we've known about this for well over a century. So it's not a new disease, but we still struggle with this awareness. And it was the white finger that was detected. That was this Raynaud's phenomenon. And interestingly, it's really dose dependent. So it's a cumulative thing. So cumulative exposure will increase risk, but a dose is the level of exposure and the time of exposure. So if you have very, very high level exposure, then actually the latency or the amount of time before you develop the condition can be quite short with extremely high exposures, as little as 2 years, and maybe even less. Okay, so what exactly is happening? What's causing this blanching in the fingers with cold exposure? Well, this is what we see on testing. So when we do a test where you measure the blood flow, it's called plethysmography, and you measure the blood flow in the fingers. What you see is just as your heart beats, you see the each beat in the blood vessels in the fingers, and then with cold exposure, those blood vessels are clamping down. They're clamping down hard. And what happens is you lose the blood flow through those vessels with that vasospasm. And so when the patient pulls the hands out of the cold water, then you remeasure, or that's what we do, we remeasure the blood flow, and you can see it's quite reduced. And in a severe case, like in this gentleman here, where in those digits where you can see that it's basically completely blanched, that would just be a flat line. So there's no blood flow happening in those digits. And so this is a way to be able to quantify. Well, it's a way to objectively actually document that the person has Raynaud's, and then it also will tell you the severity. All right, so we have researchers at Laurentian and Crosh to thank for a lot of the work in looking at the effects in the feet as well. So actually, it's kind of an interesting story. Many years ago now, we were seeing a patient here at St. Mike's, and it's very rare for somebody to have just foot transmitted vibration, or at least it used to be. It was always patients that had hand transmitted vibration and were being assessed here by us for hand-arm vibration syndrome. And the first thing that was noticed, and this was also noticed by researchers, internationally as well, that actually people with hand-arm vibration syndrome also complain of cold feet. And so this is actually caused by the sympathetic nervous system. Our sympathetic nervous system controls the level of vasospasm in the fingers and throughout the body. So it was clearly documented that somebody with hand-arm vibration syndrome would also have some degree of vasospasm in the feet. But this patient that presented, they actually didn't have any hand-transmitted vibration exposure. They worked on a McLean bolter, and that was their sole position. And they only had the foot-transmitted vibration. And he was referred here just with reported symptoms in the feet, but not the hands. So we actually did the full workup as we would for any patient presenting for hand-arm vibration syndrome. And lo and behold, he had quite severe vasospasm in the toes, but the hands were normal. This was the first time we'd actually seen this. And so we published that, and that then has led to numerous papers. There had been one paper before in 1994, but not in the English literature. And that was from somebody that actually, it was a unilateral case. He just, from a pedal, he had a lot of vibration exposure. So this is something also to keep in mind. Hand-arm vibration syndrome can also affect the feet. It can affect it because of the sympathetic nervous system. So somebody with HAVS having symptoms in the feet, or direct foot transmitted vibration can induce HAVS in the feet. The other thing we see is, for lack of a better term, some blood clotting that can occur, these vascular effects. So we talked about the vasospasm, the blood vessels clamping down, and that's a nervous system response. But also, we see reduced blood flow because there's essentially some clotting that can take place. That's what we call thrombosis. And so we see a wide range of these effects in patients presenting with a history of hand-transmitted vibration. Sometimes it's just thrombosis in the digits. That's called digital artery thrombosis. Sometimes it's actually some blood clots that are coming from further up, and then they move along, just like a stroke or a heart attack where there's blockage of the blood vessel. Same thing. You have an emboli that probably travels along, and then as the blood vessel gets smaller, it blocks it. And then the other one to be aware of, and it's not hand-arm vibration syndrome, but you see a lot of people in their jobs, they'll use their hand to basically as almost like a hammer, maybe banging a gasket or some things like that. High prevalence in automotive industry, and that's called hypothenar hammer syndrome. And that's what this picture is. So what you're seeing here is an angiogram, and you can see the arteries that look nice and straight. That's a normal looking artery. And then you see this one where there's tortuosity around there. That's a damaged ulnar artery. And that's from banging the hand and there's a little bone there, the hook of the hamate, that is right beside that blood vessel, and it damages the blood vessel. When you get a damaged blood vessel like this, it will send off emboli and then cause the blockage. In the picture on the left, you really should be seeing blood vessels going all through the fingers and nice perfusion of the fingers, but you're not seeing that here. So this is hypothenar hammer syndrome. So everyone thinks about the Raynaud's phenomenon and the vasospasm, when the hands are exposed to the cold, the blood flow stops because the blood vessels clamp down, but there's also some other vascular effects here too. And so that's something to be aware of. Now, how about the nerves? So I mentioned that the nerves are affected, and they can be affected in a variety of ways as well. On the left here, the distal in the fingers, that is true neurological hand-arm vibration syndrome. And so what that's talking about is the small nerve fibers in the fingers, they get damaged, and essentially will die back. It's a small fiber neuropathy, it's called. There's also damage to the mechanoreceptors, so the actual receptive mechanisms in the digits that are picking up the signal of, pressure and vibration and temperature. So those mechanoreceptors can be affected as well. So when we looked at the data just a few years ago now, in our large database, we have a large database that we have. It's an ongoing thing called the HAVS database with over 1,000 patients. And so we can go and look at that data and analyze it. So I had a student analyze the data around the neurological effects, and this is what was found. So about 1 in 5 patients with HAVS present with decreased ability to actually feel. And then, actually 3/4 have symptoms, but it's not of a state where it's detectable on physical examination. And then only a very small number of patients actually have no neurological symptoms. So this is very characteristic. And in at least 1 in 5 patients that we see, it's actually causing measurable impairment. Okay. And then the other thing that we see is that because these are manual, the manual nature of this work, you also see other kind of musculoskeletal and neurological things that you'd expect to see in any manual working population. Carpal tunnel syndrome, median neuropathy, and then ulnar neuropathy here at the elbow, cubital tunnel syndrome. And so the most common thing that we see in our patient population looks like just about 1/3 of patients, and maybe a bit more, have carpal tunnel syndrome that you can diagnose on nerve conduction studies. And so that's another thing to be aware of. And then finally, the bones and the joints. So we had a really great review back in 20 years ago now by Hagberg that looked at all these musculoskeletal effects in workers exposed to hand transmitted vibration. And what Hagberg basically reported is there's a lot. It's very common to have musculoskeletal diagnoses in patients that are working with hand transmitted vibration. But it's actually kind of a difficult question to figure out from a causation standpoint because of all the ergonomic factors that predispose, right? So all the repetition, the force, the posture, that also are risk factors for things like tendinopathies and joint pain and osteoarthritis, etc. So it does look like that vibration itself is an independent risk factor for those. And then the two things I put the stars beside there are clearly established where vibration increases the risk, independent of any other confounder there. So Dupuytren's contracture and reduced grip strength. Now, the Dupuytren's contracture, you may have seen this before. And so it's really, you have this fascia that is in the palm of the hand, and it clamps down. And so you basically get that clawing of the hand, and that's called Dupuytren's contracture. And I don't want to lose anyone in this forest plot picture that I have on the right. So this is from a meta-analysis. The old joke is I've never meta-analysis I didn't like. So anyway, what a meta-analysis is doing for those that are not really familiar with the methodology is looking at all the studies that appear to be valid and have good data that is similar, similar metrics, and then combining all that data to come up with more power for the study, to a more valid or reliable result. So there's a lot of debate about meta-analyses, but for the most part, it is a good way to get a massive amount of data and see if there's a true signal and also consistency in it. And you can see here for Dupuytren's contracture, there's a very clear signal with all of these studies being above 1, that's showing positive studies. And where you look at that odds ratio, that's essentially saying you're seeing more of a doubling, more than a doubling of risk. So in people that use vibrating tools. And so this is clearly established, and that's a compensable condition if it's also present if in somebody that works with vibrating tools. Now, the other thing I mentioned, decreased grip strength, and that's a little bit more difficult to figure out from a pathophysiological standpoint, because if you damage the nerves, when you don't have good innervation of a muscle, then the muscle will kind of die back. And so, it's long been known that people with hand-arm vibration syndrome tend to have reduced grip strength. And essentially it's partly because of the damage to the nerves, and so denervation, and then the muscles dies back a bit, or atrophies, I should say. But then the other interesting thing is, and I'm not a pathologist, and my histology skills are not really amazing by any means, but what the pathologists, when they look at the actual muscle in biopsy samples, they say it's not just denervation. There's something about the vibration that also damages the muscle and changes those muscle cells as well. So a couple of different things going on there from a pathophysiology standpoint, but it's very well established that reduced grip strength is also present in hand-arm vibration syndrome. So just to summarize, because I know that's a lot of information, but just remember. So actually, why don't we put up, I think we have a polling question here. Toby, I just want to see if we have everyone. Okay. Oh yeah, so let's use this. So what do you recall? Yes, okay, awesome. So everyone's really sharp this morning on a Friday morning. And so that's a really important point to make. It's the dose that makes the poison. We're going to talk about the dose in a second. And now, is there another question too? Toby, I think that there's one around the components of HAVS. All right, good. Okay. Yeah, and so, just to basically cover what we've just gone through here, is that hand-arm vibration syndrome involves the vascular system. Don't forget about the feet. The feet are a very important component, either from direct foot-transmitted vibration or also secondary to the sympathetic nervous system that changes, and then that drives it. Thrombi in the hands. So this is also part of the pathophysiology, and that one's important as well. From a neurological standpoint, the digital neuropathy, so the small fibers in the fingers basically dying back from inflammation and direct trauma from the vibration. Proximal neuropathies like carpal tunnel syndrome and ulnar neuropathy. And then the musculoskeletal effects, Dupuytren's contracture and reduced grip strength, chief among those. But we see a whole host of other musculoskeletal symptoms that vibration probably also contributes to, along with the other ergonomic risk factors. Okay, so the next question people usually have is how much really vibration is necessary to cause this? And so don't want to go into too much detail here, but essentially, if you think about vibration measurement, and there's folks, at Laurentian that have much more expertise in the assessment and measurement of vibration than I do, but the metric here is meters per second squared. If you think back to your physics, grade 10 or grade 11 physics, whatever it is, acceleration. So force equals mass times acceleration. So it makes a lot of sense to measure vibration using the acceleration metric here, because you can also do it by, displacement. You can also do it using velocity, but you thinking about vibration as acceleration, that gets at the force. So acceleration would then be, the force divided by the mass, but you're talking about force here, and it's the force that's causing the trauma leading to the vibration injury. So the vibration's measured in meters per second. It's measured in all three axes, X, Y, Z axes, and then there's a weighting that's put to it. So what's the dominant axis? And you come up with an overall number. I'm not going to spend time on this. I'm just going to show you that it's actually not as complicated as it may seem when you see a formula to say what's the AA, what's the average vibration exposure. All you're doing here is really taking the amount of vibration the person's exposed to, and you can look that up on a tool. Now, remember, field measurements are going to show higher vibration levels than what the company measures in the lab for like a whatever, hammer drill. But you just take the acceleration for that tool. You take the amount of time. So you square the vibration magnitude for that tool type. You multiply it by the amount of time the person uses it, and you add these all up. And then you divide that by the overall time, because you're trying to get an 8-hour average down here. And then you take the square root, because it's the root mean square. And lo and behold, you have an average vibration exposure for that 8-hour period. Why do I take you through that? I take you through that because now you can understand the dose response relationships. So what you're seeing here is down on the bottom is the acceleration measurement in meters per second squared, okay? And then on the y-axis there, you're seeing the time of exposure before developing symptoms. And so you can see the 10th percentile. So that would be the most sensitive people in the population developing symptoms for whatever reason. Maybe they have some predisposition, right? Everyone's a bit different. There might be some genetic predisposition, maybe a very mild sort of autoimmune condition or vascular condition that predisposes. So the 10th percentile, if you look at the 50th percentile, that's your kind of average person, right? And so here you can see that, say at 5 meters per second squared average exposure, the 50th percentile, you'd expect developing some hand-arm vibration syndrome symptoms at about 15 years there. And so this is helpful. This is what is used to inform exposure limits, this type of data. A little bit more detailed, with you looking at specifically at numbers, but this is important to understand the dose concept, because people ask, well, how much can I be exposed to? Well, it's how much, so the level of exposure, but how long as well too. So I mentioned that people could be exposed, it's been reported in as little as 2 years or less, developing hand-arm vibration syndrome. But if they're exposed to very, very high levels of vibration, see here like 13, 14 meters per second squared, whereas somebody could be exposed to much lower levels of vibration exposure, but for a long period of time, 25 years, for example, and you come up with the overall dose metric of meters per second squared years. That's kind of similar to say like a smoking history, pack years of smoking. Half a pack a day for 10 years, 5-pack years, or a pack a day for 5 years, 5-pack years, right? So it's the same metric, meters per second squared, average vibration exposure, years of exposure. So there's a European directive that essentially says the exposure limit is 5 meters per second squared on average. And if the exposure level is 2.5 meters per second squared, so half that, that's the action limit. You have to start to take measures to assess and then mitigate the risk. But the exposure limit, the absolute exposure limit is meters per second squared. Whereas the ACGIH, the American Conference of Governmental Industrial Hygienists, takes a different approach, a little bit, perhaps a bit easier to implement. So if a tool is 4 meters per second squared, then you can use that for up to 8 hours. But if it has a higher vibration exposure, so say 6 meters per second squared, then it has to be up to 4 hours, 8, 2 hours, so on and so forth. The European directive and the ACGIH exposure limit actually kind of line up pretty well if you compare them, even though they're using a different approach. So there are exposure limits there. But so for all of you in terms of this health and safety professionals, you're probably wondering, well, are there actual occupational exposure limits in our jurisdictions that we're working in, say here in Ontario? And the short answer is no, not in Ontario. Did a review of this a number of years ago as well, and it hasn't changed. So British Columbia, their Occupational Health and Safety Act does actually reference hand transmitted vibration, and they use the ACGIH TLV. New Brunswick also has an exposure limit aligning with the ACGIH. The other provinces, when you look at their Occupational Health and Safety Acts or occupational exposure limits, they don't specifically mention vibration, hand transmitted vibration. But of course, you know, in terms of the act, every act has that general duty clause, and general duty clause can be interpreted as best practice. There is guidance, whether it's the European directive or the ACGIH exposure limits. So in every province, you know, the act speaks indirectly to protecting the individual worker. Okay, so how do we go about diagnosing this? And so I just want to provide a bit of insight in terms of how this is diagnosed. So essentially, like in all of medicine, the history is the most important. Taking that history, figuring out how much the person was exposed to, and we talked about that, the level of exposure and the duration, the time of exposure, and then what are the symptoms? Is the person noticing that their fingers turn white? Are they noticing that there's numbness and tingling in their fingers, even when they're not cold? Are they noticing that they can't grip things as well, or their dexterity is down? And so that alone can pretty much give you the diagnosis, the exposure history, and then the symptoms they're telling you. Now, the physical examination can then further kind of characterize what's present and the severity, along with various investigations. The blood work we really use to make sure there's nothing else going on. It would be terrible to tell someone they had hand-arm vibration syndrome when really they have a connective tissue disease for which the treatment is completely different medications, etc. And so it's very important to do some blood work, make sure that there's nothing else going on that explains the symptoms. Then the vascular testing, this is done to measure the degree of vasospasm, or how hard those blood vessels are clamping down. And, you know, if I was just seeing a patient referred through OHIP, I wouldn't need that testing. Actually, the best practice is just show me a picture of your hands when the fingers turn white. And that tells me the severity. Most compensation systems do require some testing. Well, I shouldn't say most. You're going to see in the next few slides what the compensation systems do, but they do require some kind of objective validation. And that's just the difference between sort of seeing patients like in the community versus an administrative body that needs to quantify a severity in order to provide benefits and non-economic loss. For example, what is the quantum of that award? It's based on the severity, and so the testing is done to quantify it. Neurological testing, very important to do nerve conduction tests. If I think that the person has numbness and tingling in the fingers from the hand-arm vibration syndrome, but they actually have carpal tunnel syndrome, then again, we can treat the carpal tunnel syndrome. We can't treat the digital neuropathy. So clarifying what's causing the symptoms, and so nerve conduction tests, and then some other they're quantitative sensory tests like vibration perception threshold or temperature perception threshold can be used, or current perception threshold, which is what we use. And then musculoskeletal testing, and this is primarily the grip strength, and then the finger and hand dexterity. I've put stars beside the ones that are included in the consensus guidelines. And then the other things are done more in a compensation setting. The grip strength testing is important, again, to quantify the severity of the loss of grip strength so that appropriate compensation can be provided. So on the history, we talked about asking the person if they have symptoms of the fingers turning white, neurological symptoms, musculoskeletal symptoms, and then asking about other things that can worsen the condition or could cause some of those things, like connective tissue diseases, like scleroderma or Raynaud's phenomenon. Smoking, of course, very strong vascular risk factor, and that smoking cessation is something that we strongly, counsel on when we see patients with HAVS to help reduce the severity of their condition. Alcohol can cause problems with the peripheral nerves, and various medications can worsen or improve the degree of vasospasm, for example. So these are color charts. The one that you see, 1A and 1B, are showing the blanching. So that's a classic HAVS, whereas the other ones are showing some other conditions that can affect the fingers. Like when they're blue like that, that's cyanotic. So maybe the person has a separate condition where there's basically things in the blood, cryoglobulins, for example, or cold agglutinins, that when the hands get cold, they cause blockages in the blood vessels. Or maybe, if the hands are all blue, the person isn't getting enough oxygen. So we like to use these color charts. They actually come from the UK, just to say, what do your hands look like? And that part of the history is really important to direct us as to further testing and think about what's going on with the person's hands. The physical exam, it sounds more complicated than it really is. It's looking at the fingers, seeing if there's any blanching, but quite often in a warm environment where the core body temperature is warm, even but sticking the hands in cold water, you don't see that degree of blanching because the sympathetic nervous system isn't activated and the core body temperature is nice and warm. But looking at the fingers, then checking whether the blood vessels at the level of the wrist, this is called the Allen's test, if there's good blood flow, if the person's maybe damaged it, like with that hypothenar hammer syndrome. Looking at the tips of the fingers, if it's really severe, then the blood flow can lead to the tissue dying at the tips of the fingers, tissue necrosis or atrophy. Making sure that the blood vessels aren't being cut off sort of further up in the neck. So this would be a thoracic outlet syndrome, and we can test for that on physical exam using something called the Adson's test. Measuring the sensation using either 2-point discrimination or monofilaments, testing for carpal tunnel, just tapping lightly on the median nerve and seeing if it's quite reactive, looking for Dupuytren's contracture, and testing grip strength. So these are the fundamentals of the physical examination that's done for hand-arm vibration syndrome. And then I mentioned blood tests. Very detailed slide, breaks every PowerPoint rule in the book here. But I'll point out that the main things that we test for, again, to make sure that there's not some other explanation here that can be treated. If somebody has untreated hypothyroidism, that's going to worsen Raynaud's phenomenon. If they have B12 deficiency, that could cause a peripheral neuropathy. If they have diabetes, that could cause a peripheral neuropathy. If they have an autoimmune condition that causes vasculitis or connective tissue disease, then we want to make sure we don't miss that. And then I mentioned things like cold agglutinins and cryoglobulins, which can also present with cold-induced vascular symptoms. The other things can also be included, and you'll see them included in some protocols, but they are kind of less important in terms of the ones I've bolded are the most important ones. And then looking at the blood vessels. Or the blood vessels, if somebody has a vasculitis, then the large blood vessels can be affected. So looking at the large blood vessels, making sure that that's not the cause of the lack of blood flow in the fingers and toes. This is where we put the hands in cold water. I showed you the plethysmography and see how severe that vasospasm is. And so based on that, a diagnosis can be made. Does the person have a history of blanching? Can use photographs. That's what's recommended in the consensus guidelines. If there is objective testing, say the plethysmography, is there a significant reduction in the blood flow? The exposure history, very important. And then is there some other explanation that is potentially treatable? The neurologic testing, this is testing. So what you see in the picture here is nerve conduction studies. That's really good at picking up the large nerves that have myelin around them, so the large myelinated fibers. So nerve conduction studies, great at picking up things like carpal tunnel syndrome and ulnar neuropathy, not so good at picking up a small fiber neuropathy. So we use the nerve conduction studies to pick up carpal tunnel syndrome and ulnar neuropathy. For the small fiber neuropathy, you have to take a bit of a different approach. And so you can use, what we use is current perception threshold testing. Say in the UK, they'll use vibration and temperature. You're getting at the same thing here. Essentially, the vibration testing will test the large myelinated fibers, same as nerve conduction studies, whereas the temperature perception is transmitted through the small myelinated and the unmyelinated fibers. So you can use both those tests and you'll get a good picture of all nerve types and whether they're affected. Or you can use something called current perception threshold, which is what we do, and you measure different frequencies, and those will pick up problems in each of the fiber types. So to diagnose neurological HAVS, what we're doing is we're listening to the history. Is the person having numbness and tingling even when the hands aren't cold? What's their exposure history? What did the nerve conduction studies show? And then what does the physical examination show and other tests? And then for the musculoskeletal, we are assessing things like the tendinopathies and whatnot, because that's quite common, but specific to the HAVS, what's the grip strength? And the Purdue pegboard, I don't have a picture of that, but it's measuring the dexterity. And so HAVS is extremely disabling for people because they lose the dexterity in the fingers, can't do things like buttons, and like the difficulty is, multiplied many times over when the hands are cold. So Purdue pegboard is how we measure that dexterity. And you'll see things, the staging. So most commonly, you'll hear reference to things to the Stockholm Workshop Scale. So that's really saying quantifying based on the person's symptoms. So, if it's a Stockholm Workshop Scale of 0, then they don't have any vascular symptoms and they don't have any neurological symptoms. But you can see that as the condition gets more severe, then if they're getting blanching in the fingers and it's a lot of the fingers and it's going really far down the fingers, then you're getting a increasing stage of Stockholm Workshop Scale. And same thing with the neurological, do you have numbness and tingling? Is it present on physical exam? Is it present on actual other tests? And that gives the severity as well. Interestingly, so the consensus criteria, what happens with the Stockholm workshops, it's fairly non-specific. It's even a little bit difficult for the patient to know what occasional is or frequent. It's not well defined. So what the consensus criteria really did was scored the blanching, and this is really helped by having photographs of the hands when they're at their worst. So it lines up with the Stockholm Workshop Scale, but is a little bit more specific in the language, and also more specific about the types of tests you'll see down here that are used to make the diagnosis. So everyone is always interested in compensation, like how much do you have to be exposed to for compensation? And this is a little bit non-specific. Some of the jurisdictions in Canada really don't specify it, and others, like British Columbia quantifies it as 1,000 hours of exposure, but no level. So we talked about the dose is the level of exposure, meters per second squared, and the years of exposure. So ideally, you'd be looking at that. Now, these are policies. So if somebody doesn't meet a policy, it means that their case is adjudicated on a case-by-case basis. So you could still have an accepted claim for HAVS, even if it doesn't meet the policy. Policies are inclusive, not exclusive. At least I can speak for Ontario. But most of the jurisdictions that do specify an amount of time of exposure, it's 2 years or 1,000 hours, or you can see in Northwest Territories and Nunavut, 3,500 hours. You'll also see a lot of variability here, actually, in the testing protocols. So Ontario has the most robust kind of assessment program. Other provinces don't really have a center like St. Michael's Hospital Occupational Medicine Clinic, but BC would be the closest, and they're doing the testing for the blood vessels. They're doing nerve conduction studies, and in Quebec, they're also doing all those. And you can see in most of the other jurisdictions, it's falling back on physician diagnosis, which is fine as long as you have a physician that knows how to diagnose it and quantify it, because again, quantification has a direct impact on benefits. And then the other thing is making really good advice about prevention and return to work to protect the person. So we'll finish off here then with management, and then and I'm excited to take any questions and have some discussion around this. So the management, people know to wear gloves, to wear warm socks. They'll do that naturally. Often we have to educate and remind patients that actually the core body temperature is absolutely essential. So wearing a thing like a vest to keep the core body temperature warm. When I see patients, if they've just come in from outside and their core body temperature is cold, then you can see the blanching in the fingers. If they've been in the office for an hour and their core body temperature is warm, can stick their hands in cold water and you won't see that degree of blanching. So the core body temperature extremely important, and that's one of the management strategies. These things sound kind of very simple and straightforward, but they're super important to reduce the level of disability in people with the condition. Smoking cessation kind of goes without saying, and then other cardiovascular risk factors, you really want to optimize those. And then you can use medications like calcium channel blockers. So calcium channel blockers, they're often used as a blood pressure medication, but that's because they relax the smooth muscle in the blood vessel. And so that's the main treatment. There is some use of topical calcium channel blockers, which may also provide some benefit. We have anecdotal evidence for that, but not research evidence. In terms of neurological, if the person has a carpal tunnel syndrome, then that can be treated with splinting or maybe even surgery. But the actual neurological HAVS, the digital neuropathy, is irreversible. And musculoskeletal, so if it's tendinopathies, arthritis, which itself is an inflammatory condition, you can use medications and whatnot. If the Dupuytren's is there, then plastics can, if it's really severe and disabling, then plastics can release it, but you never really get that perfect again. And then prevention. So I know so many of you are specialists in health and safety prevention, and really, this will speak to you from a hierarchy of control standpoint. So the best thing is, elimination, of course, or substitution. Seeing increasingly sort of like, let's use the mining industry, where the person isn't necessarily right on the jackleg or stoper, but controlling it from a distance. So removing that, but if the person is using vibrating tools, hand operated, then lower vibration tools. And actually the introduction of the European standard has really driven companies to focus more on low vibration tools. So an employer having a purchasing policy would be important that has that as a focus. Tool maintenance is very important. And so I mentioned that in the field, that vibration level might be much higher for a given tool than what you see on the company website. And if you ever want to know the vibration level of a tool, you can usually, that's a good jumping off point. If you just Google that specific tool and meters per second squared, you can often find it. But if it's not well maintained and it's in the field and it's on a different surface that it is being worked on, then those vibration levels can be much higher. Education, super important. Frequent breaks, that's an administrative control, of course. But minimizing the exposure, thinking from a dose standpoint, it's still, and that's, the basis of ACGIH to minimize the duration of exposure with a given tool type. and then task rotation would achieve the same thing. Anti-vibration gloves, that's a topic for another day, but they are important. They will reduce the level of vibration. Two things. So there's a lot of research in this. The frequencies that they dampen. There's even, I mean, at some of these conferences that, you know, Tammy and Katie attend, and I've attended in the past, they get to a level of detail of, oh, this glove type with these frequencies would be good for this tool type, but maybe not so good for this tool type because the frequency distributions differ. But at a minimum, it has to be ISO approved. I've heard about these things labeled as anti-vibration gloves that are not ISO approved that actually resonate at certain frequencies and could increase the vibration exposure. So just a very strong word of warning that needs to be ISO approved. And you don't want people to have this false sense of protection over the anti-vibration gloves and then have more exposure because of them. So like all things in, where you apply the hierarchy of controls, PPE, last line of defense. And let's not forget about the foot transmitted vibration and all the work that's taking place in that area to try and reduce the exposure, which will reduce the vibration white foot, right? But will also reduce whole body vibration, I think, as well. So super important. There's good resources out there on the Ontario website. You can even find some of those on hand-arm vibration. The Health and Safety Executive is a fantastic resource for those that are interested, and even has good tools for quantifying the level of exposure where you can just plug in the tool types and the duration, and it will give you that A8 value. And the final slide here. So actually, why don't we do the final poll here, Toby? I think maybe skip the second last question and just go to the last one. Okay, well, okay, yeah, here. So what do you think about this after everything we've talked about? Yeah, so the 58% are right. It is usually irreversible. This really highlights the need for prevention. And this is the last slide here. So the neurological for sure is irreversible. That doesn't tend to come back. In terms of the vascular, I showed you the Stockholm workshop stages. And what the epidemiology shows is that once you get beyond stage 1, which is just mild symptoms, tip of the finger, occasional, once you get beyond that, it really tends to be irreversible. So best practice is when Stockholm workshop stage greater than 1 is really no further exposure. That in practice often doesn't happen. People want to continue working. They're in a job that they have a lot of expertise in, that, you know, whether, and they just want to continue. So they'll use the anti-vibration gloves, they'll use that hierarchy of controls. But this is really important. And then avoiding work in cold ambient conditions. That would be the other restriction. If we're talking about restrictions, things that, you know, the person's able to do but shouldn't because it poses risk, those are your restrictions. Versus limitations, where it's not going to pose risk, but the person's going to struggle with it, right? Here, manual dexterity, grip strength, those would be the main ones. So fairly straightforward, but you have like prevention is absolutely essential here. So HAVS is a complex disease, has the 3 different system involvement. There's variation in risk, but on average, if we want to peg a dose response relationship, it's about 25 meters per second squared years of exposure. The diagnosis is very important because you want to detect, you can't miss things that are also causing the symptoms that are potentially treatable, since we know HAVS is not. Carpal tunnel syndrome is very common, and so that is a comorbidity and needs to be picked up and treated. Don't forget about the feet, super important to protect the feet from the vibration exposure. And then this is a very disabling condition, very disabling, and prevention is absolutely essential. And so the mainstay of management is to prevent the occurrence of it through the hierarchy of controls and reducing vibration exposure. And in cases where the condition has developed, to carefully protect them from the cold, and some pharmacotherapy can alleviate some of the symptoms. And that's it. So happy, I hope that was helpful, gave you a nice broad overview, and I'm very happy to take any questions at this point.
That was terrific. Terrific. I learned a lot. I'm going to steal your meta-analysis jokes because I laughed out loud. That was good. Put a couple of them in there. Okay, we do have some questions, so I'm going to dive into them. First one is from Kathy Lynn Shaw. She's asking, would medical grade compression wear help in reducing the thrombosis?
That's a good question. You know, the thrombosis piece is an interesting area. It's interesting for two reasons. First of all, it gives us some clues about the pathophysiology of hand-arm vibration syndrome. So actually, Sandra and I were just meeting yesterday, having a discussion around biomarkers for the condition. And one of the biomarkers that's kind of a front runner in this whole area is thrombomodulin. What that is, without getting into too much detail, is this protein that sits on the blood vessel wall, the endothelium, and it's super important as an anti-clotting factor, okay? And so what happens is when the blood vessel gets damaged, then you lose that thrombomodulin. We can measure it in the blood, and it might actually be quite a good biomarker, the soluble thrombomodulin that is then released. But what it tells us about the pathophysiology is that if that's damaged, then it's going to predispose to clotting, because what that protein does is it binds, forms a complex, and then helps with anticoagulation. So the thrombosis, I've often wondered this. I'm definitely not ready for prime time, but you know, if treating the thrombosis, could that have an impact? I don't know if compression would necessarily do that. I'm thinking more along the lines of like anticoagulants, like subtle anticoagulants and whatnot. But the compression, I'm not aware of, you know, a vascular surgeon would be able to answer that a bit better. It's not something I've heard of where compression would mitigate the thrombosis aspect. So, but it's a good question. So thank you for that.
Okay, the next question is from Todd Manders. Has there been any research on white finger, white toe syndrome in a single person with no vibration exposure?
Okay, so thanks for the question. So what you're really asking, if I can interpret the question and rephrase it a little bit, is how much of this research involves controls? And so when you're thinking about controls, what you're basically saying is, I want somebody that has no hand transmitted vibration exposure or you know, negligible. Run all these tests on them and see if, you know, see if there's a difference, essentially. Are we picking things up? And so some of the research absolutely does include controls. So why is that important? It's really important because other things can present similarly. So if somebody so quite often Raynaud's phenomenon is the first symptom that really presents itself in rheumatoid arthritis, for example, or other connective tissue diseases like scleroderma present with Raynaud's phenomenon, or the person could have primary Raynaud's phenomenon where, you know, about 7% of women, about 3% of men just have Raynaud's phenomenon. And so differentiating that, so either primary versus other secondary forms of Raynaud's phenomenon from HAVS, is pretty important. And so the exposure history gives a clue, but you also need to do that blood work and whatnot. So to answer your question, if I'm interpreting it correctly, yes, the research does look at controls and differentiates so that you can sort of say, yeah, you know what? In this case, it's not other things that are causing the Raynaud's or the peripheral neuropathy. It is the vibration. I hope that answered your question.
I think so. Okay, I'm just gonna let the group know we're kind of moving into the scheduled break. So if you want to take a break, the next session is going to start on time at 10 o'clock. But Dr. Thompson, if you're okay, can we continue with a few more questions?
Definitely.
So, lots of people had the questions. So the next one, anonymous, did I understand correctly? Different provinces have different legislation on the exposure workers are allowed to be exposed to? So just
You understood.
clarification.
Yep, you understood correctly. That's the case. So I did a bit of a jurisdictional review and published that with some colleagues a few years ago to look at the legislation, and you're absolutely correct. So 2 of the provinces have occupational health and safety acts that specifically reference the ACGIH. So they would have the same ones, and those are basically occupational exposure limits. The other provinces, the occupational health and safety acts from a prevention standpoint, are silent on that. So you'd have to, ministry inspectors would have to use the general duty clause to enforce a vibration hazard.
Okay, thank you. Next question is from Aidan Robertson. Are there any best practices for medical surveillance in the workplace that you would recommend?
Okay, so I would point to the health and safety executive in the UK in terms of best practice resource. How you conduct a surveillance program is dependent on your resources. Any medical surveillance program or control program has to have those essential elements, of course, starting with management buy-in, but then doing an exposure assessment, figuring out what the population is exposed to, who needs to be included in it, and then moving to the actual evaluation or the surveillance, which has a screening component and then a surveillance. And that would involve, keeping a history of the vibration exposure for that individual, and using that, a symptom history, probably survey-based, to try and get at what symptoms they're developing. What you're trying to do is pick up early disease, and then also some physical examination component. Whether or not you add on some degree of testing would depend on the level of resources available. It's not HAVS, hand-arm vibration, is not like the designated substance regulations in Ontario, where there's specific medical surveillance protocols for those designated substances. So there's nothing like that that's laid out, but it would be quite straightforward to develop a surveillance program. Health and safety executive resources and VibRisks are a good resource there to build it around, and then you determine the resources that are being applied to it to say how detailed you want to go into it. And of course, all surveillance is voluntary on the part of the individual worker.
Okay. The next question is from Mary Jane Obie. Now the question is asking you to repeat which situations were irreversible. So I'm not sure if she means components of the HAVS itself. That's what I'm interpreting it as.
Yeah, so based on the research that I'm aware of, the neurological components, so the damage to the nerves, is irreversible. It doesn't come back. That's for sure. The vascular, depending on the research that you're looking at, some of it shows that up to that stage 1, where the person's getting subtle symptoms, that it may be reversible if the person has no further vibration exposure. But once you get past stage 2, which is more than 1 digit and past the first joint, more than stage 2, most of the literature that I'm familiar with says that that's irreversible.
And what about the muscle piece? Do you know?
The musculoskeletal piece, so the Dupuytren's contracture would not be reversible. Maybe correctable with plastic surgery, but not reversible, wouldn't really get better on its own. And the grip strength, I've never seen any research that actually measured grip strength, serial grip strength measures after cessation of exposure to see if it gets better. We're highly dependent on things like OT interventions and the compensatory like exercises and whatnot. So yeah,
There's a study, eh?
That would be a good study. That would be a good study. You really have to control for like interventions. Yeah.
Okay, if you're still good, there's a few more questions here. Maxime Vincent is asking, and first she says, thank you, very good presentation. She's wondering about like shock vibrations. So for example, like a nail gun, and if you could comment around gender effect, perhaps, or sex effect.
Mhm.
So 2 questions there, shock and sex.
Both excellent questions. So there is work that's also done on impact vibration. It's not as robust a body of literature as other more typical continuous vibration. So, I mean, just from a pathophysiology standpoint and mechanism standpoint, an impact vibration will potentially pose higher risk of, that vascular injury, for example. But it lends itself less to kind of those dose response relationships, right? From a cumulative exposure standpoint. So the answer is yes, impact vibration can clearly induce hand-arm vibration syndrome. It can be a risk factor, but we don't know as much from a dose-response relationship to quantify that. In terms of differences by sex, it's different. It's an area where, say, we see about 200 patients a year, we might, like 195 of them are men. So this is there's less research to really inform it, the differences, because we can't power the studies well enough. And, this also, as with all long latency diseases, you're seeing a shift now, right? But it's delayed. So, if you look back, most of the workers that we're seeing, they're kind of nearing retirement and they're coming to get assessed. And so we're talking about exposures that took place over the last 30 to 40 years, right? The demographic of the workforce in, say, construction, mining was quite different 40 years ago than it is today. So it's increasing, where we're seeing more and more women presenting with hand-arm vibration syndrome, and I suspect, just due to anatomical factors, that there's probably is higher risk, to be honest, and that's for a variety of reasons, physiologic reasons, but also things like tool design and anthropometric measurements and grip strength. So if a tool is not an ideal size for your grip, you have to grip it tighter. If you grip things tighter, you have more transmission of the vibration. So there's a whole host of both individual physiologic factors that probably predispose anatomic, as well as workplace factors and the tool interface. So I would hypothesize higher risk, but I can't tell you that from data.
That's really interesting. Look at all the studies we've come up with now. Okay, we probably only have time for one more question, maybe two. We'll see. This one's from Kelsey Kelday. If HAVS can be diagnosed as either neurological or musculoskeletal, will they show symptoms from both systems immediately, or like time frame of development?
It's a very good question. I would say that most people, they usually occur concurrently. It's the most common presenting symptom are the vascular symptoms, and then when you chase after the neurological symptoms on the history, then you pick those up. So the vascular tend to be more prominent, from just a clinical standpoint than the neurologic, but they occur concurrently, and there's probably some degree of bidirectional relationship between the two as well, because prolonged tissue ischemia, or lack of blood flow, will also contribute to the neuropathy. So another mechanistic reason as to why the vascular symptoms probably come first and the neurologic second. But they usually but they can occur concurrently.
Okay, last question goes to Judith Nelson. When workers take a break during work, is that helpful because the body's recovering from the vibration, or is it because it's reducing total exposure time?
I would say both. So reducing the exposure time is ultimately what's going to reduce overall risk. But if you think about that and the vibration itself, what's happening there is the vibration is inducing the vasospasm. And the vasospasm is happening for a variety of reasons, but part of it is that sympathetic nervous system is really getting engaged. Okay, and so you can measure that with things like heart rate variability decreases. The sympathetic nervous system is overriding the parasympathetic, and then the blood vessels can't relax. And so giving the frequent breaks enables that to settle a bit, and also to get reperfusion of the fingers with the blood flow. That's going to ultimately reduce the risk of long-term damage. So the frequent breaks is actually very important from that standpoint, in order to provide an opportunity for those blood vessels to relax. But they take a while. You know, even with the cold exposure, you see prolonged rewarming. And so it takes, 10 to 15 minutes.
That's really interesting. Really, so they should be doing parasympathetic stimulation maybe during the break. They can be humming,
There's a
meditating.
lot of work. Yeah, there's a lot of work, Sandra, on biofeedback as a treatment in general for
that's awesome.
for Raynaud's. So yeah.
Okay. Well, I mean, just a delight. Wonderful presentation. I'm so sorry that we can't get to the rest of the questions because we do have to start the next session. But you may get some phone calls now for more talks. That was terrific. Thank you so much for your time. We know you're busy, and yeah, I think everybody learned a lot. So have a good day, Dr. Thompson.
Thank you, everyone. And it was an honor. And thank you for the great questions. And look forward to seeing you all soon. Have a great day. Bye for now.